Welcome back to Beyond Well. I'm Sheila Hamilton, and today we're going to have an in-depth discussion on suicide prevention with Robert Nikkel. He is the executive director of the Mad in America Continuing Education Project, clinical assistant professor in the public psychiatry training program at Oregon Health and Science University, and he served as the state of Oregon's commissioner for both mental health and addiction from 2003 to 2008. It's so great to welcome you back to Beyond Well, Bob.
Thank you, Sheila. It's good to be back on.
You know that suicide prevention is a topic that I sort of have devoted my life to since the death of my late husband, and your take on suicide and why the numbers continue to climb is so interesting to me. Could we just start there with where we're at in the efforts to try to get people to find alternative ways to their suffering rather than suicide?
Sure. I think we're at a point where we're starting to re-examine some of the old assumptions. So it'll be kind of fun to talk about this.
Well, in 1999, suicide rates hit a 50-year low. Since then, there has been a 30% jump in suicide since 2000. And you point out that the paradox is that that has coincided with the use and increase in psychotropic medications. Is there a link?
Well, I think we're still looking at that. I think it's fairly clear from the research now that some people become more suicidal, partly because of agitation and other things, once they start taking antidepressants and once they stop taking them. And it doesn't appear that antidepressants really are that effective even for depression, but it actually elevates risk from what the data is telling us early in treatment and once people begin to go off them.
One thing that I always think back on was the big effort that it took by family members, especially of kids who took antidepressants and then had suicidal thoughts, to get a black box warning. Why hasn't that been broadened to include middle-aged Americans, older Americans who start on these drugs?
Well, I think there are a couple of reasons. One is in order for a black box warning to be posted, you have to go through an extensive process with the Federal Drug Administration, the FDA. And I think it takes time to get really good, well-crafted, unbiased research into that kind of a public sector. So I think that's part of it. It's a time issue. I think there's still a lot of resistance to the idea that antidepressants could actually elevate, because it's so counter to, first of all, what messages have come out about it. And just the name antidepressants makes you expect that antidepressants would relieve depression, and it's not really clear that they do.
The American Foundation for Suicide Prevention has been promoting suicide awareness programs since the late 1980s, and they talk about how 90% of people who die by suicide have a mental health disorder. But more recently, the CDC has been noting that up to half of people who die by suicide actually don't have a diagnosis. So talk to me about that disparity.
Well, I think that's another paradoxical pattern here. You'd expect that once people have a psychiatric diagnosis, particularly depression, or even for the psychotic disorders, you'd expect the risk to go up. But it does look like many people who don't carry a psychiatric diagnosis really do have an elevated risk. And I think we're still trying to understand why that would be. You know, the two major factors that influence suicide rates are unemployment and access to guns.
Yeah,
those are clearly issues that we have to be looking at more than we have.
Yeah, it's the societal issues that people have not wanted to look at. I was also fascinated at the data that shows the link between suicide and home evictions. Yes,
I think those are factors we're still trying to integrate into our thinking as mental health professionals.
So if we're not going to focus on getting people into mental health treatment to either help alleviate the suicidal ideation or to get them medicated for whatever it is they're doing, what sort of path is there for a person who has decided to end their life, that they're in that much despair?
Well, I think there are two things that we're beginning to learn more about. One is something that's happening right here in Oregon with the Washington County Public Health Program. They've, over the last 6 or 7 years, reduced the suicide rate by about 40%. And that's a pretty incredible reduction in the risk. They're doing it by understanding more about what people who are serious about suicide begin doing in the weeks or so before they actually make the suicide attempt. For example, people who are seriously suicidal will take their pets to an animal shelter. What Washington County has begun to do is train people who work in animal shelters to know how to ask questions in a way that it begins to get to the person's consciousness that maybe they could get help. But these are things that have really come out of a more in-depth look at the factors and the period of time before people actually commit a serious suicide attempt. So I think looking at public health issues is one of the things that we're going to be studying more and more. One of the presentations we're going to have in the Continuing Education Project that I direct is by Dr. Kim Repp, who is a public health officer for Washington County, and she's going to talk about this particular finding in more depth and what they're actually doing there. She's getting a lot of national and even international attention, so we're really pleased that she's agreed to do one of our webinars.
I also just want to talk about the red flag laws that have been passed in several places, including Multnomah County, which would allow families who have a person in their family who has clearly expressed suicidal ideation to be able to take their gun for a short period of time. How do you feel about those programs?
Well, I think given that gun ownership, having a gun in the house is a huge risk factor. People who have a gun in the household are about 3 times more likely to make a fatal suicide attempt. They may not actually have a higher elevated risk, but because they have a gun, when they do make a suicide attempt, it's more than an attempt. It's a reality. It's pretty hard to survive a gunshot wound to the head, right?
One of the questions that I always have around this, Bob, and it's especially because our entire insurance system and everything that we actually support people in terms of getting medical care is all based pretty much on the antidepressant model. It's based on seeing a psychiatrist or psychologist who prescribes something, who sees you, and then your insurance actually pays for that visit. So it's almost as if we need a complete re-education as to some of the factors that could actually help, because even payment is based on this belief that it actually makes you better.
Right. I think that's one of the things we have to look at is more how policies, whether it's private insurance policies or public policies, influence the prescription pattern. You know, in the public sector, which I was involved with for decades, you know, doctors are paid largely to do 15-minute medication checks. Mm-hmm. And as long as that's the fiscal incentive, it's going to be hard to change some of these patterns that we're seeing. We have to find ways to pay just as well or better for psychiatrists or social workers, psychologists, and sometimes for peers to be available to people who are beginning to be serious about suicide so that we can do something other than prescribe drugs for them if that doesn't seem to be the factor that's most effective in lowering suicide risk.
So I also want you to talk just a little bit about this continuing education project for people who might be listening and interested in this particular topic. How can they get involved in that, Bob?
Well, I think given this is a podcast interview, I think the thing to do is Google Mad in America Continuing Education. And if they want to add suicide, that would be a way to come to our website quickly. Once you get there, you register for the courses. We have started feeling like we've got to be more self-supporting in this project. So we're charging what I think is a pretty modest fee, $150 for a series of 11 webinars. You don't have to, it's not $150 per session. It's $150 for the entire series, the entire course. So anyone can register. We actually have a fairly mixed audience. We certainly have mental health professionals because they can get continuing education credits. And that's psychologists, social workers, nurses, licensed professional counselors, and marriage and family therapists. We used to try to offer continuing medical education credits, but the process was so expensive, it was so time-consuming, and frankly, we had so few medical doctors who would sign up that it just wasn't worth it. If we had a lot of doctors begin to clamor for continuing medication credits, I'd be willing to look at that. But we also have family members. We have a lot of people with lived experience. We have advocates. And you and I have been talking about a way to get more interest among a group of journalists.
Mm-hmm.
We're really trying to have a fairly broad audience. It is geared as professional education to mental health professionals. So we always have to be clear about that. But we welcome anybody who's interested to sign on. The webinars have a live webinar date, but we also upload every one of the webinars. So they're up there within about 6 hours. We have webinars that are still up there from 5 years ago. So our hope is that people can participate in these things. It's not quite as good as the live interviews, but people can have access to the presentations and the materials.
I've been very interested in the link between repeated psychiatric, especially forced psychiatric evaluations, and the risk for suicide, that it's like 27 times higher for people who have had contact with emergency rooms, forced care, that sort of thing. But I want to also be sensitive to the needs of family members who have gotten to the point with their loved one where they fear for their own lives or perhaps the life of that person. So what is the alternative to people who are in the midst of somebody who is in this type of care? There's nowhere you can take them save for a jail. What do you suggest they do?
Well, I think that's a real gap in the system. Partly, we have confidentiality restrictions so that once a person is in treatment, it's pretty difficult for a mental health professional to talk to family members without permission.
Yeah.
But I think that's something that we need more advocacy for, frankly. Again, because the finances of the public system and the private system aren't set up very well to, for example, fund a resource in crisis centers that would be available to family members. Mm-hmm. We also simply have to get accurate information out about what helps. Because if we just tell family members to get their loved one into treatment, and that means going on to antidepressants, it may actually elevate the risk for some people.
There's always
to get accurate information.
Yeah, go ahead. I want you to continue that thought, Bob. You said you need accurate information, but at this point, as far as I know, MAD in America is one of the very few places where people and your organization, the Foundation for Excellence in Mental Health Care, can even find alternatives. Is there a bigger burgeoning movement to find alternatives to the current system that is serving people with mental health disorders?
I really don't know the answer to that, Sheila. We're told that our continuing education project is unique. The accreditation organization that works with us tells us we're one of a kind, and they do national work. Wow. We also have an international audience. We've had as many as 12 different countries represented as participants on some of our past webinars. I think that says something about the kind of vacuum that there is for information of this sort.
Yeah. I'm very interested just because I have worked with a couple of hospitals in developing a peer network, and I'm always amazed at the benefits of having somebody who has actually been through a similar type of depression with suicidal ideation before in talking with a person who's suffering. It almost seems more important than nursing care, really.
Yeah, 4 of the 11 webinars we have are actually peer approaches. So that we're thinking that we need more research on it too, but everything we know about peer supports says that it's an incredibly valuable resource. And really people really gravitate to those kind of peer groups for support once they know about them and once they're available.
Yeah. If you were someone listening, and I know that there is always people who are on antidepressants and especially mood stabilizers and other type of antipsychotics right now who will say, I would not be alive if it weren't for my medication. What would you challenge them to do to try to find out more information about perhaps an alternative path?
Well, first of all, I would respect anybody who feels that the medications have been helpful. If they learn that they might be able at some point to go off them, or they begin to get concerned about the potential risk, then the advice that I would give them is to be very careful and cautious about going off them. We're still learning about the psychiatric withdrawal effects of all of the psychiatric medications. In fact, our continuing education project, we've had not one, but 2 entire series of webinars on the very topic of psychiatric drug withdrawal. So it's not something that should be taken lightly for people if they do want to try to go off any of the psychiatric medications, to do it very carefully and very gradually. I would say, too, they need to work very carefully with their physicians. One thing to realize, too, about antidepressants is about 70% of antidepressants in this country are not prescribed by psychiatrists. They're prescribed by general practitioners, primary care doctors. So we also need to reach out to organizations such as Doctors for America, which actually has as its president of the board a primary care doctor right here in the Portland area. And I've begun talking with them because they're an organization that I think is pretty open to thinking about things a little bit differently.
Oh, interesting. I want to talk just a little bit more about drug-induced suicidal ideation. And I went through this with my late husband because within 24 hours of taking an antidepressant, he was in akathisia. And my understanding is that's a pretty good sign that the antidepressant has not been good for the person. It's been horrible for the person because they're in a state of extreme fluctuating moods, terrible like internal hell, pacing, itching, tongue. When they stick their tongue back and forth, it's one of the most frightening things to witness. And so what percentage of people who go on antidepressants, Bob, end up in this state of akathisia?
To be honest, I don't know the exact percentage, but it is a fairly common reaction. And akathisia is such an uncomfortable experience that partly accounts, I think, for the increase in risk, as I said earlier, once people begin to take the antidepressants. And once people go off them, I think that's a period of withdrawal. And you can see the same kinds of increases in anxiety and other kinds of reactions toward the end of treatment as well.
What are some more holistic ways of going ahead in trying to treat mild depression and mild anxiety rather than going down the heavy medication route?
Well, I think, one of the things I would suggest is look at nutrition issues, and I'm certainly not an expert on it, but one of our most popular courses, in fact, the most popular course in 5 years has been one that's been on the role of nutrition in dealing with mental health challenges. So I think nutrition is an important piece. Most of us really struggle to find healthy foods. When you walk into a grocery store, the first thing that hits you is literally a wall of sugar-based drinks.
Yeah.
When I walked into the Fred Meyer's near me, that was literally the first thing you walk into. It was literally a wall of pop.
Yeah, exactly.
So I think those are some of the things that have to be looked at.
I also just think it's fascinating, this link between the gut and the brain now, and how much more science there is showing that those microglial cells are taking whatever it is that's in your stomach straight to your brain and your thought processing. I think that that's really a fascinating area of research that's going on.
Yeah, I would agree. So I think, even food colorings for kids are associated with some elevation in things like attention deficit disorder, which frankly, I think is diagnosed probably too frequently. There are usually other kinds of social, family, and sometimes nutrition factors that really drive that kind of behavior. There's no question that the behavior is there. Question is what's really causing it, and are the psychiatric drugs really effective, particularly in the mid to long-term effectiveness of them.
Yeah, it's also, I think your point isn't lost on people who have lost loved ones to suicide, how important it is to try to get help for the societal pressures, the economic pressures, the loneliness epidemic that we have in America. All of these other factors can be more important than what's going on in the brain of someone. It's not so much a chemical instability as it is sort of a crisis of mind, body, and spirit. Everything's going wrong when you're suicidal, right?
Yeah, and I think that's part of the strength of peer approaches is when you can talk with somebody who's actually been through it. First of all, you don't feel quite as alone, but you can also pick up some real tips on how to avoid it. For me, I dealt with depression my entire life. The single thing that helps me the most right now is going for a 4-mile run every day.
There you go.
I always feel better afterwards.
No kidding. Yeah. Also, just the role of mindfulness and being able to sort of take the garbage out on your brain is so helpful. You know, it's great to learn some of these other things just for regular coping as well. Well, Bob, it's been great to talk with you again. And the Foundation for Excellence in Mental Health Care supports this program. If you want to find out more, just click on the link below. Thanks again, Bob.
Okay, thank you, Sheila.